So we have a series of questions here. Let me kind of queue them up. So let's see. All right, so which item is used in the pressure ulcer measure? So this is for the quality reporting program. M1311 or M1313. What was said today in the QRP training was said differently than what has been reported previously. And I'm sorry if there was any confusion, but I thought it was pretty clear. The item used in the calculation of the QM is 1313. We trained on 1311 because understanding how to code 1311 helps to understand how to code the new or worsened pressure ulcer in 1313. But M1313 is the one that is used in the measure. All right. So the next question is, can you explain why we see warning on our validation reports showing there is a HIPS code change from what was originally submitted on the extract file? And the answer to that is, this question should be referred to the payment policy staff at homehealthpolicy@cms.hhs.gov. So that's a payment. But often you would say it's like usually a software. There's a, yeah.
I apologize. It's typically a sign that it's called a 257 error, and it just basically, it comes back to you because of the fact that the software that you're using is not the most current software, that either your vendor has done some configurations with what you purchased from them, and it's not calculating the same HIP score as what we calculate in our repository. But our repository is what should be the HIP score that gets submitted on the claim, and that determines the amount of your payment when you submit your actual claim for the home health service. So I always encourage people, if you see that happening, you really ought to reach out to the vendor that you bought the software from and have them figure out and determine why their software is giving you a different HIP score. And what I've often come across in my old days was that the software was not updated with the latest version of the grouper.
Okay, great. Thank you so much. All right, next question. Stage 4 pressure ulcer has a skin graft, so now captured as a surgical wound. This heals and remains epithelialized for greater than 30 days. It's now a scar and not captured on the OASIS. If this same area reopens due to pressure and clinically looks like a stage 2, can we capture as a stage 4 since the underlying tissue wasn't replaced as would happen with a muscle flap? And so the answer is skin grafts are considered surgical wounds because the skin grafting is a surgical procedure where the skin is sewn in to a defect to close the wound. If a stage 4 pressure ulcer was closed with a skin graft, the surgical wound healed, and another pressure formed in the same anatomical location due to pressure, then this pressure ulcer would be staged as a stage 4. It is important to remember that regardless of whether the stage 3 or 4 ulcer is closed using a skin graft or via granulation tissue, that the original tissues are never actually replaced like you would if your skin had never had the injury. These ulcers can be closed using skin graft, yet are more likely to have recurrent breakdown even after such closure, and so prevention efforts should be adhered to in order to prevent reoccurrence of the skin breakdown if at all possible. But really the short answer is you'd code it as a stage 4. Okay. When will we again have a centralized and standardized resource for the OASIS Q&As? Right now, it takes up to 3 weeks to get an answer for the OASIS questions. In speaking with OEC, learn that the process now is for the OEC to try to answer using current resources. If no current guidance is available, then the OEC emails all the OECs in other states for their opinions. This communication can go back and forth with discussion over several points, and the ONC finally pulls together various opinions and responds to the question for the requesting agency. There have been situations of different answers in different states, which threaten standardization of data collection. It is essential for agencies to have a resource for timely and consistent answers to OASIS questions, especially as they get new items for the data set. So do you want me to just read the answer and then you can comment on it, or do you want to just kind of comment on it?
No, we definitely hear you, and we are giving you the manager of that area, but we're also going to be working through in the coming months with her leadership to try to come up with a process that where we would find a vehicle to be able to put these answers into one repository. I hear you. It's not the ideal, and it's definitely not where we want to be as an agency. So stay tuned as we work through the process of how we can get answers to you in one consistent medium.
Okay, great. And then, so with our answer though, so we did add an email. If you feel like you wanted to email someone on this, you can to Peggy Wilkerson at cms.hhs.gov. So Peggy, P-E-G-G-Y, Wilkerson, W-I-L-K-E-R-S-O-N, at cms.hhs.gov. And again, these Q&As will be posted, so you'll be able to get that information. Okay, there have been discrepancy amongst surveyors in regulatory education re-diagnosed related to POC. Some people still insist that if a patient is on a med, there should be a diagnosis to substantiate the med. Others educate us to use the diagnosis appropriate for patient current medical issues. Re-diagnosis, for example, hypothyroidism, does not need to be on the POC unless hypothyroid is not under control. And so I will read the answer, and then if anyone else wants to comment. The question should be referred to Peggy, so now you have her email, in survey and certification group, as it is pertinent to conditions of participation. And then I gave you her, her email. So I think really what it came down is we're not giving regulatory guidance on the plan of correction. Is that maybe?
Yeah, well, the plan of care is something that we don't truly interact with until we're doing a survey as an agency. We wouldn't necessarily know what's in the plan of care, so that's where we're going to find that you're reporting something, and that's where the survey is probably going to give you the guidance about how they believe you should have populated the plan of care based upon the patient's conditions. So we're going to reach out to Peggy and try to get some feedback about the fact that we've heard what we've heard today. Everything that's here that's being recorded is going to be available to us an agency as we go back and we talk internally, and hopefully we'll be able to get some consistent guidance.
Thank you. So current Q&A guidance states that if a patient is unexpectedly discharged, the last clinician to see the patient is allowed to complete an OASIS and must complete the discharge OASIS based on their last visit findings. For OASIS items where a dash is a valid response, should a dash be used on the discharge OASIS, or should the item be answered based on the findings from the visit last made? Or do we answer based on findings from the last visit unless it's something not assessed on the last visit, and then use the dash only in this instance? And then an example. For example, a PT may not have assessed an ulcer at the most recent visit if it was under a dressing, but may have visualized an ulcer that wasn't covered by a dressing. So I'm not sure. Do you want me to just read the answer and then, or do you guys want to? Kathy, you got it there? Okay.
In the case of an unexpected discharge, the last qualified clinician to see the patient should complete the discharge OASIS based on their last visit findings. If an issue was not assessed by that clinician on that last visit, a dash indicating that no information is available or the item was not assessed could be used for those limited OASIS items where a dash is a valid response in this situation. In situations where it is discovered that there is no one person at the agency who has all the information needed to complete the assessment, it may not be possible to produce the discharge assessment. This, of course, means you are now non-compliant with the condition of participation, 484.55, comprehensive assessment of patients.
On the discharge, so 13, so you're talking like, yeah, so then you wouldn't really, the thing is, you wouldn't be able to code 1313 either, right, if it's new or worsened? New, hopefully you'd be able to see it, but worsened if you're not able to assess it. If you don't have, so the question is, if you don't have the information, and you can't obtain the information, a dash is a valid response.
But you could have, like, in 1311, if I saw a stage 2, I could put down, yes, one stage 2, and yes, it was present. But then for the stage 3, because I didn't change the dressing that day on the stage 3, I could put a dash for that particular one and then move on to the
Right, so it
stage
depends
4.
on
So I
which
could have a
question you're
mix.
asking, like if it's a stage 3 and you're asking B1, was it present on start of care? You should be able to know that if it was there or not.
So we could mix it, though. You could have
Right.
some dashes and some numbers. Okay.
Right. I mean, a dash is a valid response. Again, they're meant to be used, though, rarely, so you really should do every effort that you can to assess it. But it is a valid response. Can a nurse practitioner follow a patient at home, sign clinical verbal orders, or must it be co-signed by an MD? Can the MP order lab tests for patients? So I don't know if you want to address that, or I can just read the answer. I can just read the answer, fine. This is a payment policy question and should be referred to home health policy at cms.hhs.gov. And you know that that's a pretty complex, right? That's a condition of participation and it's a complex issue, and then there's state guidelines as well. So I don't know if there's anything else you want to add to that, but.
I think from my perspective, I thought the question was stemmed from the need to have a physician order. So there was an assumption on our part in reading in that question. So if that is indeed, then yes, I concur with what you just provided here, that, quite a bit of information out there about the physician needing to sign the order and the limitations for non-physician practitioners not being able to sign the order. So if that is incorrect, someone can let us know and we can revise and post another question. But I assume that was the intent of it.
Right. Okay. Another question, is it enough for the physician to sign the 485 to confirm diagnoses? Is the interim order absolutely necessary?
I think, again, you're going to find yourself in a situation there where the only time we look at the plan of care is when we're out there doing a survey. So if we're out there doing a survey, unfortunately, we don't have the staff here today that are doing the surveys that lead that effort. It is under Peggy Wilkerson's direction, and they would be able to answer how they would handle that particular, in terms of whether or not they would accept what the nurse, what was on that paperwork, or whether or not they look for some other standard. I really can't answer that one. You're past my understanding of survey and certification. So rather than speculate, hate to say this, but we would give you, we'll post these questions and answers out here, but it's going to be a referral to Peggy Wilkerson for a more definitive answer.
If the question is referring to 1028 for the confirmation of the diagnosis as to whether a diagnosis is present and or active, the guidance does say that you have to have written confirmation from the physician. And so you can do that in the form of an order. That's the easiest and most expeditious way to go about that. If, in fact, that's what you're looking for, if that's what you're referring to here, is how am I confirming PAD, PVD, or diabetes when it hasn't been spelled out anywhere, but the inferences are all there. The guidance does say you need to have it confirmed by the physician that yes, it's present and yes, it's active. So in that case, then an order would be the easiest way to go about it.
Okay, great.
Clarification purposes, it has to be an order, or can we write a clinical note? If we had a conversation with the physician, write his name, date, and time, and that he confirmed that. Do we have to have an order?
I think we're splitting hairs. How is he going to confirm it? You simply need something in writing from the physician that he has signed. And so however you choose to go about that, you're going to have something from him that says, yes, this patient has diabetes and it's in active treatment right now.
Okay, so it has to be the doctor's signature on whatever method we used.
Whatever method you use,
Gotcha.
and that's why I say an interim order is the easiest way to simply send something that says, please confirm. Patient is being actively treated by you, and the nurse is to assess for diabetes, for PAD, PVD. They sign it and send it back.
Yeah, well, we send summaries on admissions to the physician. We fax them, and they'll sign it that they received, and they agree
Okay.
with our intended plan of care. So
Okay,
that's why I was
but
wondering,
that gives
does
you
it
a
have to be
signature,
orders or
and
not?
that is what you're looking for. You are getting a signature.
Okay.
Okay, great. During response to questions from the floor, Ms. Roby indicated that you would leave weight blank if unable to obtain. Chapter 3 does not include instructions to leave either measures blank. Rather, we are to use the dash value when unable to obtain. Please clarify. And so, Kathy, I don't know if you want to read the answer, or I can. Basically, the item cannot be left blank. Providers should use the dash if unable to obtain a weight. So a dash, again, is a valid response. I don't know if you have any other comments there, Kathy. No? Okay. When will interpretive guidelines be out for the July regulations that are now delayed until January? Having interpretive guidelines can assist in policy decisions. And guess what? We said, please refer your questions to Peggy Wilkerson. Her email is. Right, that's what we were saying. She'll be notified. She asked that these things come through,
Yeah,
right?
she did. That was the direction that we got from her, and I think that this will help solidify for her that there's a need. But I think there's an extension. Someone referenced July, but I believe it's been extended. So.
Okay. Right. For CMS, it says for CMS, patients have rights, including the right to refuse. I'd like to know why home care either gets dinged in Quality Star ratings for patients who have their flu shots at MD offices or unable to be weighed, i.e. greater weight than 400 pounds, and financially dinged for face-to-face and lack of medical office records. Agencies spend a lot of time/money trying to get physicians to supply what we need. We have no control over MD's actions, yet we are the ones who will have financial implications for not getting what we need. There's an answer.
I think in completing that, going back to being financially dinged, if the patient's received it in another setting, there's an option on the item response that you can indicate that. So I'm not sure that I would necessarily agree that you're being dinged. I think the same can be said for the other item response in the question.
So the weight one was that it's used as a covariant, and actually the covariant around pressure ulcers is around a low BMI, not a high BMI. And so in this particular example, over 400, you're not going to get dinged for it, so it is a covariant used that really is a risk adjuster.
And in terms of the face-to-face, we're going to kind of play. We're here to train you on the item set, and the face-to-face policy is reimbursement. So, but I believe Hillary Loeffler, the manager over in that area, is definitely available. If anybody needs or wants to reach out to her, I'm willing to give you her email address, and so she can respond, or one of her staff can respond.
Okay.
I think we've addressed, I think that's it for that question.
Okay, great. In question GG0170C, the patient used her bed prior to her fall. After discharge from the hospital, she sleeps in a recliner. How do we score this? Ann, do you want to answer? Okay. The answer's right there. It's on the sheet. I should say the vetted
Very
answer
small
is on
type
the
here.
sheet. Oh, that's not the right answer. So basically,
Yeah, the answer to that really is that if the patient is using it's a chair, is that the
Yeah,
recliner? That would be their usual bed service then. So you would be using that to score GG versus her, requiring her or saying that she refused or was not safe to go to her bed. So you would be using the recliner as the usual bed surface and would score GG based on the recliner.
all right. Who set and requires OASIS C2? Fee-for-service, Medicaid, what about Medicare Advantage or Medicare HMO? That was kind of a vague question, but we did try to answer it and said CMS requires for OASIS completion is CMS requirement for OASIS completion is required for all skilled Medicare and Medicaid patients, excluding pediatric and maternity. This would also include managed Medicare and Medicaid. So I'm not sure. Hopefully we answered that question. If we didn't, we ask that you can resubmit a new question. But we took from what was written on the card that that's what the question was. All right, we're getting there. Next question. Within the start of care 5-day window, if an RN goes in and the patient refuses to perform the task of lying to sitting that day, the physical therapist goes in for an evaluation visit the next day and the patient agrees. Can both disciplines collaborate upon the PT assessment and RN can complete GG, or does it have to be the RN going in again within the 5-day window? In our agency, the PT cannot do SOC OASIS. So there's
Unfortunately, in the home health world, we have what's called the one clinician rule. So if you look at our guidance, we're pretty clear that it has to be the patient, the specialty that's completing the assessment at the end. So if you're not able to do that, you can't rely upon others to, you can glean. I think the distinction though is that they can assist you with providing information, but you are the one that's responsible for completing the assessment. However, we know that there's some variation between this and other settings, and I have brought this up since I have taken on this role. I've brought this up before our leadership, and it's something that we plan to brief on them on soon regarding whether or not this policy is appropriate. And we'll see where we land with that. Because we do understand we are trying, where possible, in CMS to align across settings.
okay. So the next question says, what happens if the start of care occurs on a weekend, example, a Saturday, and the RN finds a medication issue? The MD is unavailable within the 24-hour period. What do we do? And actually, we talked a little bit about this, Joan, that you were going to kind of in general address, because there was a lot of questions that came from the floor on this.
I'll repeat this one again.
Sure. So this specific question is, what happens if the start of care occurs on the weekend, example, a Saturday, and the RN finds a medication issue? The MD is unavailable within 24-hour period. What do we do? So the answer that we gave, but I think you wanted to expand a little bit on this, just on all the comments that came out, is the clinician reports the issue to the covering MD and complete the recommended actions. So that's what we should do. But I think you were going to try to comment on just general some of the frustrations and concerns that the audience had around all the medication
I think
issues with the
one of the
doc.
things I really wanted to say is that we heard you loud and clear on this issue today, and it's something that we will definitely be taking back and providing feedback to our leadership regarding the concerns that you, as in fact, we're probably going to use the video. So they hear it firsthand without an interpretation from CMS staff regarding the frustrations that you're having in terms of being able to report on this item and report on it effectively. I think one of the things that I think anyone in any organization will tell you is sometimes, we get it right, sometimes we don't. And, but that doesn't mean that we don't remain flexible and that we don't try to figure out ways to not only address your concerns, but address the concerns regarding the quality of care. So, although we're focused on how we can ensure that the patient's getting the best of care, we also want to ensure that it's possible for you to be able to meet the measure. And I heard quite a bit today.
Great, thank you. The next couple are probably for you, Kathy, starting at line 25, just so you know. During medication reconciliation, how far do we look back when the patient has multiple longstanding medications? What is the CMS regulation on the time frame?
The medication reconciliation only pertains to medications that the patient is currently taking. So that the question says, during medication reconciliation, how far do we look back when they have multiple long-standing medications? I'm not sure what you're looking for, why you're, what the reference is. Yes, ma'am.
Right.
But the question then is this patient currently actively taking that medication? Okay, then if they are currently actively taking it, then it needs to go onto the med profile, and it needs to be reconciled against whatever your referral intake orders are. Was it on the hospital referral list? Did the referral come from long-term care or rehab? Was it on that list? If it's not, then it needs to be reconciled. A phone call needs to be made to the physician to say, this is what's in the home. They're telling me they're still taking it. They must be putting new pills in the old bottle if the date is from 2015, which, believe me, does happen. But we need a confirmation from you as to, are they to be taking this or not? Yes, that's right.
Okay, great. Thank you for that clarification. Great. Okay, so next question. The drug regime review is done at the SOC ROC, but how about medication updates during the weekly visits?
Again, the medication update itself is not what you are measuring in the quality measure. However, this is considered to be a best practice in assessing the patient during a visit. So that, as I said when I was going through this with you, what you are assessing when you are answering the questions 001, 2003, 2005, what you are assessing at that time is, what's happening right here. But it is a medication best practice to review, confirm, educate the medication regimen profile with the patient, caregiver, family, et cetera, during your regular visits. But the question is only addressing what's happening right there at that time.
Okay, great. Thank you. Next question. If a patient is missing a medicine at the SOC and there is a plan for the med to be picked up, can a clinician use judgment and select 0 no? For example, a patient ran out of calcium 600 milligrams supplement today, but the caregiver is picking up more later in the day. The clinician determines this is not of a level of significance that requires contact with the MD by midnight of the next calendar day. Can 0 no be selected? And the answer is?
The short answer is yes.
Okay.
But
Okay.
again, as we said earlier, you need to consider how you are ranking the level of clinical significance for the medication issues that you are identifying. And you should have some form of a validated resource and a process that you are going to follow in assessing, yes, it exists, and this is the level of significance, and that is why I decided, yes, I had to get in touch with the physician and act by midnight of tomorrow, or no, I don't have to.
Okay, great. So next question. I'm wondering why CMS did not use urinary incontinence as a risk adjust covariant for the risk of pressure ulcers as new or worsened, since the condition is more frequently encountered in home care. It's actually probably more encountered in most of our healthcare settings. That's a good question. And actually it's been asked at a couple of trainings, and so it's based on the data analysis of the PAC-PRD data, and that they looked at both bladder and bowel incontinence, and both were considered, but bowel incontinence was a stronger predictor of new or worsening pressure ulcers. So it was around research that was done on this. So that's the reason when they weighed everything out, they chose the bowel incontinence. Okay, last question for what we have here. Please expand on directing clinicians on using clinical judgment to determine if an issue is clinically significant. And then 1, our EMR has numerous alerts. Some are things like may require dose adjustment. I would not think that this is significant. Number 2, I would hesitate to recommend clinicians entering all the meds into a secondary system or app. Increasing time may be confusing. And then number 3, physicians are complaining when they are informed about med combinations that patient has been on for years without an issue. And 4, therapists are especially hesitant not to inform the physician, I think it should be to inform the physician about every alert. And then 5, could it be that the physician should be aware of an issue, but may not require the 24-hour time frame and is therefore not clinically significant? There's an answer in there, so.
Determining whether or not a situation is considered potential clinically significant medication issue is completely up to the clinical judgment of the assessing clinician. And this was on one of the slides. If you go back through, it actually does use the phrase in the judgment of the clinician. This includes interpreting the EMR drug review alerts. It is possible for a clinician to determine in their best clinical judgment that the physician should be notified of an issue that does not require the timing of by midnight of the next calendar day and therefore does not meet the definition. They might have decided, well, yes, he does need to know, but he doesn't have to know emergently by today or tomorrow by midnight. But he does need to know. And so in that case, they would notify, but it does not meet the definition of a potential clinically significant medication issue as defined by this item. So again, in the best clinical judgment, and you do need to have something to support that judgment with. Okay?
Great. Thank you. That's the end of the questions that we have been able to get through. There were additional questions that are getting entered into our database and still being submitted. All of these will be reviewed. I think there were a couple that were kind of left out because it needs to go back to CMS leadership for review where we couldn't come to consensus as a team or it needed more input. It's not that those are being ignored. Those will be answered. And all the Q&As will be posted. But it has to go through a process back at CMS, and then these will be shared, as you had indicated, to all the appropriate groups. So that's the reason it's important to put your questions and your thoughts in writing. We appreciate that. That concludes our 2-day training. We thank you very much for coming and being part of this. Please, please, please fill out your evaluations. We look at those very, very closely, and those help to formulate next trainings and how we present our information. So if you would give us that information, we greatly appreciate it. Thank you for coming, and everyone have safe travels.